Now, I work in a neurological ICU, so I see a lot of stroke patients. But what I'm going to try to do here is just keep it really simple and just give you the basics of stroke and kind of what you need to know to pass nursing exams and the NCLEX without going into it very much or too deep here. So a stroke is essentially, it's a neurological deficit caused by decreased blood flow to a portion of the brain. Okay. Now we have ischemic versus hemorrhagic stroke. And we're going to dive into this quite a bit here. And a lack of blood flow greater than 10 minutes can cause irreversible damage. What you see here is you see an ischemic stroke several days after the initial stroke here. So this would be the right side of the brain, this would be the left, because images are reversed on CT. So this would be a large right-sided stroke here. And these would be the ventricles of the brain. So this patient is has a massive stroke here, right? So basically, though, but regardless of whether it's ischemic versus hemorrhagic, what we're concerned about here is this decreased blood flow to the portion of the brain. Much like a heart attack, if one of those vessels becomes occluded, or if one of those vessels ruptures, we have that issue where blood flow is then not progressing beyond that point, and without the blood flow, it's not getting oxygen, and then we have tissue death, right? Okay, so that's what a stroke essentially is. Now let's talk ischemic versus hemorrhagic. When we talk about an ischemic stroke, we're talking about, of course, a blood clot. This makes up about 87% of all strokes, and it's not initially identifiable on a CT. So what happens is a patient comes in with stroke-like symptoms, right? Altered levels of consciousness, facial droop, and things like that. And so we automatically are concerned that it could be an ischemic stroke. And we begin interventions for that. So that's kind of the concern there. With hemorrhagic strokes, what we have is we have a bleed. We have a weak blood vessel ruptures, and the patient will generally call this the worst headache of their life. So a lot of times what we'll have like an aneurysm on one of the vessels in the brain, and this portion of the aneurysm here is generally the weakest part. And so what will happen is eventually that could rupture, and then that would cause blood flow out of here, and then we'd lose blood flow distal to that. And so that, of course, is a huge concern as well. Both of these, as you can see, are limiting blood flow beyond that point. Okay, so here's be an ischemic stroke with the blood clot. This would be like a hemorrhagic stroke with blood being lost into cerebral space. Okay, so with hemorrhagic stroke, though, this is identifiable on a CT immediately because we'd see all this blood inside the cerebral space. Okay. So some of the risk factors, what do we need to watch out for with a patient who may be at risk for a stroke? Now, this is going to be similar risk factors for many things that we talk about, right? Because our risk factors are hypertension, diabetes, atherosclerosis. And so with all these here, we're talking about vascular issues, right? So these are making our vessels weaker, and they're making our vessels less adaptable to blood flow and things like that. So blood is less able to flow, vessels become weaker, and then atherosclerosis, of course, can lead to clots. We can also have cardiac dysrhythmias. If we had an AFib even, that could cause clots to dislodge and head up to the brain. Substance abuse, a lot of times we'll see patients with cocaine abuse that can lead to stroke. Obesity, of course, we're also talking about vascular issues there, as well as buildup of fat within the vessels and leading to ischemic stroke. Oral contraceptives actually pose a risk factor for hemorrhagic stroke. Okay, and then anticoagulant therapy. Of course, if we're thinning a patient's blood, we get their INR up to like our goal level of 2 or whatever, or 2.5. Whatever their goal is, that makes them much more of a candidate for bleeding. So if it's an elderly patient who has less balance and things like that, and they fall, that puts them at a big risk for like a subarachnoid hemorrhage with blood collecting in the cerebral space, or a subdural hematoma, something like that. Okay, so how do we assess this? First of all, it's clinical assessment. Like I said, we have to be able to assess for stroke symptoms. Facial droop, they're not talking right, they have altered mental status. We can do a CT And initially that would help us be able to find, like I said, a hemorrhagic stroke, or like an ischemic stroke a couple days after. You can also run an MRI. It's going to be a little bit more conducive to being able to see a stroke. And then we can do a cerebral angiogram. That's this here. We can actually inject a dye up into the cerebral space. And this is what would be done with an ischemic stroke. If we assume an ischemic stroke, the physician would go in there, the neurosurgeon or interventional neurologist would go in there and be able to inject this dye and be able to see where a stroke is, and then be able to, a clot is, and be able to remove it. Okay, and we'll get into that in just a minute. So again, our assessment: altered levels of consciousness, contralateral manifestations, opposite side of the stroke. Now, and again, this is going to be dependent upon where the stroke is, whether it's basal ganglia, whether it's pontine, whether it's supra or supratentorial. So based on where the stroke is going to kind of tell us some of the assessment findings. But for our purposes, we really just need to keep in mind this: facial droop. Arms, does one arm drift, meaning does it fall down if it's lifted up? Are they not able to lift it? Or speech problems, are they just acting different? Okay, a lot of times patients will come in and they'll just say, grandma was talking funny after dinner, or something like that. And then we can also do what's called an NIH stroke scale. This gives you a score, basically grading how significant the stroke is, up to 40 or so. And the higher the score, the more significant the stroke was. And so we kind of judge both sides. We judge their ability to read, their orientation, and then we give them a score based on that of how significant the stroke was. Okay. So some things you need to keep in mind here. You'll hear a lot about these: aphasia, apraxia, hemianopsia, dysphagia. So what are these things? Aphasia is speech difficulty, and there's a couple different kinds. There's expressive, receptive, global. And so some of the things with expressive, it's going to be they understand, but they're not able to express themselves, right? With receptive, they're not able to comprehend. So they're not receiving, they're not receptive of what you're saying. With global, that's language dysfunction, okay? And so these can be, like, the first time you actually see a patient who has this, it can be very surprising kind of to hear these patients talk, and they really believe they're making sense, but they're making no sense at all. Or you show them like a picture of a glove and they call it a key, and they really just believe they're saying the right things. So the best thing we can do for these patients is provide adequate time for the client to respond. Okay, we need to not be rushing them through assessments, and we need to make sure they're able to have the time they need to respond. We need to repeat names of individuals and objects frequently. We need to repeat ourselves. My name's John, I'm your nurse. Remember, I'm going to be taking care of you. We can use a picture board that a lot of hospitals will have. We can provide only one instruction at a time. So don't say, let's get up, let's go to the bathroom, let's get back down, let's watch the TV, here's your call light. You need to do things very slowly for these patients, okay? Apraxia would be the inability to perform tasks. So you would ask them to write their name, and they're not able to do it. Hemianopsia is blindness in half the vision field, and this is one of the tests we do with our NIH stroke scale. Is we'll show them a picture that kind of has something happening on one side of the picture and something happening on the other side of the picture, and we ask them to just tell us what they see in the picture. And so they'll have a picture. It's actually a picture of a mom over here doing dishes, and then over here there's a couple kids kind of grabbing into a cookie jar. And so people with hemianopsia, they'll only be able to see one half of the picture. This other half just becomes completely absent, and they just can't see it at all. So what we can do here is we can instruct the client to turn their head to capture the entire vision field. So if they're really only being able to see from one side, we need to tell them to make sure they're looking around everywhere. We need to approach them from the unaffected side, and we provide food and objects to the unaffected side. We're not trying to trick our clients here, and we're not trying to cure them with hemianopsia. Then we might not be able to ever do that, but teaching them to adapt to that is what we're trying to do. And then dysphagia is difficulty swallowing. Okay, so keeping those things in mind, some things that we can do for ischemic stroke. With ischemic stroke, we actually allow for permissive hypertension. So we'll allow their blood pressure up to 220 over 110. And the reason for that is, remember, we have this clot here, right? And so blood is not flowing as it should. So we want to pump up that blood pressure to try to get as much perfusion as we can. Okay, so it's always fun with new nurses to watch them freak out when they see a blood pressure of 180 on an ischemic stroke patient. So we really want to get that blood pressure up and try to perfuse as much as possible. We could also provide antithrombotic therapy. This would be like TPA. Now, with a patient with TPA, we actually bring that blood pressure down a bit because there's a huge risk for bleeding out with TPA. So what TPA actually does, it goes in, so it's antithrombotic, right? So we have this thrombus in our vessel, and the TPA actually goes in there and bam, it busts that up. Okay, it's pretty cool. Then we have a carotid endarterectomy. So let's say here's our patient. Here's their carotid artery. Let's say they have a clot here. They can actually open this up and pull that clot out. Okay, so pulling that clot out there would then allow blood flow back up into the to the brain. There's thrombectomies as well. With thrombectomies, that's kind of when the CTA would be used. The patient will go into interventional radiology, and the physician will actually go up to that clot, encase it, and pull it out. Okay, so it's pretty cool watching that, and so that would restore blood flow. And then we're obviously going to monitor neurological status. With our hemorrhagic stroke patient, remember this is completely different. What we'll do here is we can do coiling or clipping of an aneurysm. So remember, we have an aneurysm here. So the physician will go in here with like a little wire, and they can actually throw wires in here to coil that. And what will happen is that will actually start to clot over, and then blood flow is restored, and we're not worried about this rupturing anymore. Okay, so that would strengthen all that aneurysm there. So that would be with coiling. With clipping, they actually go in and do a cranie. They'll open the skull and they'll go in and actually clip this off. Okay, so that's kind of the difference in coiling and clipping. With these patients, one of our biggest concerns is going to be to prevent spasming of these vessels. Okay, we want these vessels to continue to keep the blood flow as they should, and so after we do this coiling and the clipping, we kind of get their blood pressure up just a tad again and make sure they're getting enough blood flow. So we dilute their blood, we give them more volume, and we make sure they're getting all the blood they need, the blood flow volume that they need. Okay, so that's kind of how we manage those patients. Also, we want to monitor for seizure precautions with blood. Anytime blood comes in contact with other vessels and things, we can have seizures. We want to monitor neurological status. Are they improving? Are they getting worse? Trying to make sure I don't get into this too much here. We want to make sure that they're not getting worse. So to monitor neurological status, one thing we're going to do is we're going to assess pupils, make sure, so this would be like unequal pupils here. We want to, of course, we're looking for PERLA, pupils equal, round, reactive to light, and accommodate. We want to maintain a quiet, calm environment. We want to assess for need for assistive devices and get physical therapy and occupational therapy involved. And then we want to get speech therapy involved to make sure they're able to take their foods and their medications as needed. Okay, so that's just the basics of stroke. Of course, we can go into this much more. It's a